Welcome to our webinar titled Vexas Syndrome. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the webinar today. Due to the high volume of programs on the internet, it is possible you may lose your connection during the program. If you are unable to view the program online, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in your question in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. Submit your entire question all at the same time. Second, please don't share private health information in your question. Our speakers cannot answer any specific questions related to your health care. Our specialists today are Anna Cantor and Dr. David Beck. Anna is a board-certified genetic counselor specializing in cancer and immune genetics. Her clinical and research work focuses on providing genetic diagnosis for people with suspected immune degeneration disorders. She has a particular interest in promoting genomic education among healthcare providers and is a clinical supervisor and mentor for genetic counseling students. She earned her MS in human genetics and genetic counseling from Sarah Lawrence College in New York. Anna also has an MA in behavioral neuroscience from the University of British Columbia in Vancouver, Canada, and completed her MA in psychology from Condor University in Montreal, Canada. Dr. David Beck is a principal investigator of the Beck Lab and runs the Inflammatory Disease Genetics Clinic in the Department of Medicine at Memorial Sloan Kettering in New York. His research focuses on identifying the genetic causes of human diseases, as well as the means to better understand diagnosis, treat patients, and understand the basic biology principles. Dr. Beck received his BA from Brown University in the departments of history and biology. He earned his MD and PhD from the New York University in the laboratory of Dr. Dan Reinberg. He continued his clinical training in the clinical scientist pathway in internal medicine at Columbia University, and then went on to perform clinical genetics training at the National Institutes of Health and Johns Hopkins combined program. Dr. Beck performed his postdoctoral research with Dr. Dan Kastner at the National Institutes of Health. It's my great pleasure to welcome Anna and Dr. Beck. Thank you for joining us today.
Thank you for having us. Let me just share our screen. Is this full screen?
Yes, it is.
And just one clarification, we're both at New York University. So for anyone interested in contacting us, we'll have the contact information at the end. But we tremendously appreciate having you here and talking to you about Vexas Syndrome. Take it away, Anna.
Thank you. So good afternoon, everybody. Here's an outline of our talk today. So I'm going to start off by going over, a case of a male who presented to the NIH. I'm going to go over what Vexas syndrome is. I'm going to pass it over to Dr. Beck, who's going to go over why having a genetic diagnosis is so important. Then he'll go over some of the background information on what led to the discovery of Vexas syndrome and some ongoing research efforts. So here we have a 55-year-old male who presented to the NIH with abdominal pain. As his disease progressed, he experienced systemic symptoms, which included fever, some chills. He had some redness and swelling around the eyes. He had some rashes, and he was started on steroids, which helped his symptoms. But as he was tapered off the steroids, his symptoms came back. Eventually, he was found to have swelling and pain around the outer ears. He had some hearing loss, and he was experiencing blood clots. He was diagnosed with macrocytic anemia, which is when the red blood cells are abnormally large. He underwent a bone marrow biopsy at that time, which was unrevealing, and the concern for him was really a diagnosis of myelodysplastic syndrome. So again, his disease progressed, and he was given steroids, which he responded pretty well to. But almost 3 years into the course of his disease, he had failed numerous disease-modifying anti-rheumatic agents. All right, so this is a really great example of a hallmark feature of this patient's condition. During one of his flares, they drew blood and they tested his C-reactive protein level. And this is an inflammatory marker that's present in the blood. And just for reference, a normal CRP level is under 5. And so during one of his flares, he had a 79 CRP. And as he started tapering his steroids from 20 to 15 milligrams, 2 days later, they redrew his blood and his CRP level was 382. And what this really goes to show is that this gentleman was very sensitive to steroids. And so he then presented to genetics and he underwent exome testing. And exome testing is where we look at all 20,000 genes in the body. It's a very comprehensive test, especially for 2013. Throughout the course of the next few years, his symptoms worsened. He required high-dose steroids and he was transfusion dependent. So he was getting blood transfusions, he was getting platelet transfusions, and he was hospitalized multiple times for liver failure as well as renal failure. And then finally, he received a diagnosis of Vexas syndrome. So what is Vexas syndrome? So Vexas syndrome is an auto-inflammatory disease that's caused by mutations in the UBA1 gene. So auto-inflammatory diseases are a class of diseases that arise due to problems with our innate immune system. And what happens is that our immune system has an incorrect reaction. And so inflammation occurs because our immune cells target our own body's healthy tissue by mistake. And this signals the body to attack itself. And so when that happens, people can experience fevers and rashes and joint pain. And so in Vexas system, we see it occur everywhere throughout the body. So people with Vexas syndrome are usually diagnosed later on. The onset is typically over the age of 50. It affects primarily males, which I'll explain why in a little bit. And patients are often carrying other clinical diagnoses, as you see here. I'll explain a little bit more about it later. But at the current time, there are no clinical or diagnostic criteria for Vexas syndrome. So what does Vexas syndrome stand for? So one of the classic or characteristic features of Vexas syndrome is that people who undergo bone marrow biopsies, they have these little vacuoles in their bone marrow. And you can see that they kind of look like bubbles. Some of our patients call it Swiss cheese. And so this tends to be present in the biopsies of our patients with Vexas syndrome. E1 ubiquitin activating enzyme, which is encoded by the UBA1 gene, which is mutated in patients with Vexas. And Dr. Beck will explain a little bit more about this later on. The UBA1 gene is on the X chromosome, and males have one X chromosome. and females have 2, which is why men tend to present with this disease more frequently than females do, because women have a compensating X chromosome, if you will. As we discussed, patients have autoinflammation. And these UBA1 genes, mutations are somatic. So that means they're acquired throughout one's life and they're not inherited. So as we saw in the case of our patient had numerous areas of the body that were affected by inflammation. And so the question is, why are so many organs affected? So UBA1 mutations occur in the bone marrow. And the bone marrow is responsible for the site of blood cell production. So this is where red blood cells are produced, and white blood cells and platelets, and these circulate throughout the body. And so in Vexas, we do see the systemic inflammation. We do see that multiple organs are affected. And so when we see inflammation in the skin, that's what's responsible for those rashes. When we're seeing inflammation in the cartilage, we're seeing the pain and the ear and the nose swelling. When we're seeing inflammation in the lungs, we're seeing the coughing and the shortness of breath. When there's inflammation in the joints, we're seeing the swelling and the pain. And in the blood vessels, we're seeing vasculitis. And so if we go back to our patient, if you can see those red arrows, these are all the symptoms that our patient had prior to his diagnosis of Vexas syndrome. And another important thing to note, this is the reason why patients are carrying so many different clinical diagnoses. And so here's a slide of some of the clinical images that were taken from the initial cohort of Vexas patients at the NIH. In the top row, you'll see some imaging which shows inflammation in the lungs and the alveoli of the lungs of patients with Vexas syndrome. You'll see some of the characteristic rashes. Another key feature of Vexas is that patients have injection site reactions. So that's the picture E on the left. On the third row, you'll see the inflammation in the cartilage. So the outer ear, the nose, underneath the eyes, they're red. And then the final row, you'll see some dysplasia or some of those characteristic vacuoles that we see in the bone marrow as well. And so the patients that are diagnosed with Vexas, they have the same diagnosis, right? They have all these UBA1 mutations, but they have different clinical diagnoses. And so the patients that were in the initial NIH cohort, you can see that they met diagnostic or classification criteria for these types of diseases. So these are patients that were diagnosed with relapsing polychondritis or Sweet syndrome or MDS or MGUS. And as you can see, the same genetic diagnosis presents with different clinical diagnoses. And if we move on to the types of symptoms that patients are presenting with, the first column here is the initial cohort. The second column is the second cohort of NIH patients with Vexas. And so you can see the manifestations. There's a range of manifestations. And if we go back to our patient, he definitely did present with a bunch of these different symptoms. But again, the underlying takeaway from this is that patients have the same genetic diagnosis, but the manifestations are different. And you can see here that some of the really common features here are fevers, rashes, lung inflammation, the inflammation in the cartilage, so in the ear and the nose, and the macrocytic anemia, those abnormally large red blood cells. And so the question is, why do mutations happen? Mutations happen all the time. And they occur because of errors in the repair of damaged DNA in our body. Most changes that happen, most mutations that happen are benign, but they happen more frequently as we age. And you can see this in the diagram. There are certain factors that influence the number of mutations that occur. One good example is cancer. So the average diagnosis of most cancers are in the 60s. And our risk for getting cancer is influenced by a host of different factors. So things that can influence our development of cancer are environmental exposures and toxins, such as smoking, can influence the risk of developing lung cancer. UV radiation can influence our chance of getting melanoma. Aging is also a big factor here. That's why most average ages of diagnosis happen later on in life. And viruses can also influence disease. So we know the HPV virus, for example, is a really big, is responsible for cervical cancer. And so these mutations happen more frequently as we get older. And we know that these mutations are happening, they're considered acquired or somatic. And what does that mean? That means is that as we progress through life, we accumulate these mutations, but they're localized. That means they're present in one organ and they're not present throughout the body, and they're not present in the sperm or in the egg. Mutations that are present in the sperm or the egg are germline mutations, and that's when we can pass things on to the future generation. And I know for our Vexas patients, this is a very big concern for them. What is the risk for me passing this disease on to children? And because the mutation is localized to the blood and it's not present in other tissue and it's not present in the sperm or the egg, there is no risk of passing this disease on to children. And so why does this matter? Why is it important for us to have this genetic diagnosis? So I'm going to pass this over to Dr. Beck, and he's going to pick up the presentation.
Hi, everyone. Thanks again for having us. I'm excited to talk more about Vexas. Our goal with genetic diagnoses is to be able to provide better care for patients. Understanding the exact reason why they have the symptoms they do allows us to better understand how to treat the disease, why they have the manifestations, and what will happen next. And those are some of the tenets of precision medicine. So being able to find the genetic cause for these diseases like myelodysplastic syndrome and lupus in a small subset helps us provide more personalized care. So here's kind of a way of thinking about it is that we think about UBA1 as a genetic reclassification of clinical diagnoses. So many of the genetic diagnoses that we have stand alone. They aren't found in clinics, but this disease actually can present in many different ways. So we know that it's present in 1 in 4,000 individuals over the age of 50. We know that the penetrance, so this is a quite common disease, the penetrance of it is 100%, meaning that 100% of individuals who have the mutation have symptoms. And the phenotype's diverse. So having a UBA1 mutation can lead to rheumatic manifestations and diagnoses like lupus, rheumatoid arthritis, relapsing polychondritis, giant cell arteritis, hematologic diagnoses like myelodysplastic syndrome, macrocytic anemia, multiple myeloma, cardiac, pulmonary symptoms, diagnoses, sarcoidosis, interstitial lung disease, myocarditis, pericarditis, and also skin findings. And this is probably just the tip of the iceberg as we're learning more about this disease. And why we think it's important to the genetic reclassification is patients with the UBA1 mutation behave differently than other individuals with the same clinical diagnosis. And this may be very confusing for individuals in the audience, is that you've carried a clinical diagnosis or a loved one has carried a clinical diagnosis for years. But what's important is why they have that manifestation. And here's an example. So we know that the Vexas can be a severe disease. The median survival time for Vexas from symptom onset is 10 years. This is significantly different than some of the diagnoses that I listed before. And why that matters is some of the other diagnoses may not be treated, may not be managed in the same manner. Understanding that this is a disease that needs treatment is critical. All clinical research ultimately is aimed at getting back to helping individuals. And so identification of a genetic cause is only as good as being able to treat them, patients. So right now we know this disease is a severe inflammatory disease that's associated with cancers in the blood. And it responds mostly to steroids, to glucocorticoids. We know that bone marrow transplantation can be curative in patients who are eligible for this treatment. Now, this is a treatment, as many of you may know, that can come with adverse events, and it's not something that we would offer as a first-line therapy, but something to consider for patients who are refractory to other treatments and who are currently kind of in a severe state of disease. And for that reason, my colleagues at the NIH have started a transplant protocol, which is still at the stages of clinical trial. But the idea is that this may become standard of care for patients who can't get relief from medical therapies. In addition, we're in the process of developing a medical therapy with a multi-center international trial. And here I'll just present some of the preliminary data about how we can use the UBA1 mutation as a way to guide improved care. So this is a study that I participated in that was led by a French consortium studying patients with Vexas. And they decided to treat patients with a drug called ruxolitinib, which is a JAK inhibitor. That's a specific pathway involved in inflammation. And this is not a treatment that's typically used in rheumatic diseases. It is in blood-borne cancers. And what they found on the left is that patients who received ruxolitinib versus different drugs, so that's the red line, actually didn't need any change in medication. The majority of them, 100% to 80%, did not need to have any change in therapy, which is a proxy for saying that they were responding well. And on the right, you can see that the ruxolitinib patients at 6 months out had a significant decrease in the amount of steroids they required. So those are those blue boxes. The red boxes are ruxolitinib, the blue are other medications. So this is early signs that if we use treatments more targeted at the mutation rather than the clinical diagnosis, we can get improved response. And this is just a year and a half after recognition of the disease. What we're hoping is that by increased recognition, increased reporting, and collaboration, we can expand upon these findings and find even more effective therapies going forward. So I want to change gears a little bit and talk about why this diagnosis was only recently identified. You know, if it's so common and, 1 in 4,000 individuals have this, why was it missed? And this I've had to explain to many of my family members. So a major reason why is that most genetic sequencing is done for childhood onset diseases or familial diseases, where it looks like there's an inherited cause. And the reason is, in adults, we think that the diseases occur because of environmental factors, acquired factors over their lives, and not really genetic causes. So, and most adult onset genetic sequencing is focused on cancer. So some of you may know about genetic testing that happens in cancer, where we look at tumors and we sequence for looking for driver mutations for treatment. So if you don't have cancer, frequently adults don't get genetic testing. And similarly, there are research studies that look at common genetic mutations. I don't want to spend a lot of time here, but common genetic mutations are ones that sort of define who we are. They don't cause disease necessarily, but they have small impacts on our health and well-being. And together, many of them may work to cause adult onset diseases. But there've been very little genetic studies looking at adult onset diseases and even less studies looking at inflammatory diseases. So we decided to look at genetic sequencing across a number of individuals with severe refractory inflammation. We decided to look at pathways that we thought might be important in inflammation. We looked across the 1,500 patients who were sequenced through Dr. Kastner's cohort at the NIH and the undiagnosed diseases cohort. And we decided, let's not just pick out things that we already know. Let's look for anything that comes out in these pathways that's shared. So sort of an unbiased, whatever will come out genetics. What we found was 3 patients, all middle-aged men, all with mutations in this gene, UBA1, that had ill-defined inflammatory diseases, meaning they had gone through sort of a circuit of getting different diagnoses and not really responding to treatment. And what was initially confusing is that UBA1 is an X chromosomal gene, as you heard, and men should only have 1 copy of the X chromosome. And these patients seem to have 2 different alleles, 2 different UBA1 genes, despite the fact that they only have 1 X chromosome. And this I'm pointing to with this little arrow. You can see there's 2 peaks on this DNA tracing. And this is confusing because each cell only has 1 copy. What's going on? Well, it actually turns out that when we looked outside of the blood, in the skin, there was no mutation. So this is showing that the mutation is an acquired process that occurs in the blood. And not only is it acquired in the blood, it's acquired within certain cells in the blood. So I'm not going to go into all detail here, but just to show you that some of the cells in the blood here shown in blue, the innate immune cells, these are the first line defense against infections, have the mutation. And our B and T cells, the cells that work in longer term immune responses, don't have the mutation. So it's found only in the blood and only within specific cell subsets within the blood. And so just to add on to that, we can actually quantify this in a different manner. And this is a different technique than these tracings, and be able to look that the mutation is not detectable even at the lowest level within these T and B cells. So we found 3 patients, they had the same mutation, and they had some very ill-defined disease. We wanted to look at their other features of their clinical diagnosis to see if there were clues. And what we found was that they had all had bone marrow biopsies as part of their clinical diagnostic workup. And all 3 individuals had these Swiss cheese vacuoles in the cytoplasm of their cells. So this is the kind of pointed at here. This is the area around the nucleus, the center of the cell. And they were abundant. They were present in all 3 individuals. And these are unique findings. They are found in some nutritional deficiencies, but they're now helping us provide a clue when patients have UBA1 mutations. And what I'll say is, from these 3 patients, the clinical information, the steroid responsiveness, the pathology, we were able to find 25 individuals within weeks. And we were able to find hundreds of individuals within months. So this was lying there. These diseases were out there in clinics. Patients weren't getting diagnoses. And using these other findings, we were able to diagnose many individuals. So what is UBA1? UBA1 is the gene that's mutated in Vexas. Well, we want to know how it functions so that we can understand how better to treat these diseases. So UBA1 is an initiator of the ubiquitination process in the cell. So ubiquitination is a process in which proteins, these are sort of the engines, the worker bees of the cell, proteins are tagged for degradation. Ubiquitin is a small tag that sends them to the garbage can. And ubiquitination occurs through 3 sequential steps. There's the E1 enzyme, E2, and E3 enzymes. These lead to the garbage can, the proteasome, and then degradation of proteins. Now, it turns out that UBA1 is the major E1 required for initiating all of this tagging and degradation. And in the cell, the vast majority of proteins are degraded at any one time. So really, UBA1 is regulating an enormous amount of proteins, an enormous amount of signaling pathways. So what's happening with these mutations? So when we look at the mutations in cells, what we find is that they're present at one single spot most of the time. And this is this one part of the protein called methionine 41. And what happens when we have this mutation is that there's a change in the amount of UBA1 in cells. So what we see is that UBA1 usually has 2 different isoforms, 2 different proteins. One is a long form that sits in the headquarters, the nucleus, and another is a shorter form, which is in the cytoplasm. When we have mutations in Vexas, we see that there is a loss of the cytoplasmic, the short form, UBA1B, an emergence of a new isoform, UBA1C, which is impaired. So together, in Vexas, we have a loss of the activity of this important enzyme, within the cytoplasm of cells. And really the model for the disease, how it works is that we have a somatic mutation that happens in the blood. These are these blue cells in the middle panel. They occur in the earliest cells in the bone marrow, and then they become lineage restricted. They stay in only one cell type within the bone marrow, and then are found in these myeloid cells. These are the innate immune cells. And the lymphocytes don't have the mutation. And at the subcellular level, when we zoom in on the cell, what we can see is that the mutant cells, the blue cells here on the bottom, have a loss of the cytoplasmic UBA1B, an emergence of a new catalytically impaired non-functional protein called UBA1C. So together, this is leading to a loss of this pathway. So we're very interested in understanding how Vexas works. clinically research standpoint with the idea of providing better treatment for patients. So I run a program that's a mixture of clinical care and basic science research. So one of our initiatives is to study animal models, mice that have these mutations so that we can better understand why UBA1 mutations lead to inflammation and how better to treat these. I'm also focused, or we're focused, on trying to identify the complete spectrum of mutations that cause Vexas and what other genes other than UBA1 may be causing disease. So this is important because although we're providing diagnoses for hundreds of individuals, thousands, many people don't have a diagnosis. And a diagnosis is a step toward being able to get therapies, to get effective treatments. So we're there looking for more genes in a similar manner to what we did previously. And then I'm very interested in knowing why UBA1 leads to this disease, knowing the steps in between the mutation and why there are these manifestations in patients, because that will clue us in how to treat these individuals. And finally, we're here at the AAMDS. We're learning more about the clinical manifestations of Vexas, and many individuals have something like myelodysplastic syndrome. What defines UBA1 Vexas versus myelodysplastic syndrome? How should they be treated? How should they be clinically managed? Is this the same diagnosis or different? We're trying to learn this right now so that we can provide better care for individuals. And we do this in our clinic. So we have an inflammatory disease genetics program at New York University. It's multidisciplinary. We both see pediatric and adult patients with the idea of trying to provide a more precise molecular diagnosis with genetic testing. The goal is that the genetic diagnosis would be a step towards treatment. And when we can't provide a diagnosis with what we know in clinical testing, so there are a few hundred genes that have been implicated in disease, we go into research and we dig deeper into patients' genetic material to see if we can find a cause. And we would be happy for anyone to reach out with questions they may have about our research program, clinical guidelines, if we can help with anyone's care or their unsolved diagnosis. And with that, I just want to thank the tremendous amount of collaborative work that's happened to allow this to occur. You know, the original discovery of Vexas occurred because of a large number of researchers working together at the NIH, including Dan Kastner, my boss, Peter Grayson, who's a rheumatologist at the NIH, and Neil Young, a hematologist who's affiliated with MDS aplastic anemia. I also want to thank the members of my lab now who've been very helpful in expanding on our understanding and the support that I've had at NYU. So with that, I'd love to take any questions you may have or any comments. Thank you.
Thank you so much, Anna and Dr. Beck, for the presentation. So we have quite a few questions. Our first question is, have you found Vexas to be in connection with MDS patients that have more than one mutation, such as MDS patients that may also have a TP53 mutation?
That's a really good question. We have found patients, and we think that the UBA1 mutation is the dominant part of the disease, meaning that if a patient has a UBA1 mutation, they're more likely to respond to the treatments that we've been discussing rather than the other mutations that they have. But it seems like the UBA1 mutation can co-occur with many other MDS-defining mutations. But predominantly what we've seen is that when you have a UBA1 mutation, you end up having a phenotype, a clinical manifestations that are more inflammatory than general myelodysplastic syndrome.
Thank you. And to tag on to that, have you found patients who are diagnosed with Vexas syndrome, does that impact their treatment, such as for MDS? Would it weigh into the clinical decision of how to treat someone's MDS?
So back to the previous question before we go there, the vast majority of sequencing that's occurring for MDS does not include the UBA1 gene. So gene panels are tested for bone marrow samples, and we don't know who has or does not have those mutations. So, it's going to change. Meetings like this and our efforts are changing that because it's going to be a clinically important test, and it just appeared in some of the clinical guidelines. But right now, we're learning a lot from expanding panels, and I think that it's still a work in progress understanding it. To the question that you're asking now, it's sort of relevant again. My impression is that the UBA1 mutation is going to be a risk factor for how you treat MDS. Just like some of you may have heard of these scores that have come out of big collaborative networks like the IPSS in terms of risk stratifying so we can plan treatment for patients. We think, and others think, that UBA1, when it's included in that study, it will have an implication. And when we talk to hematologists and rheumatologists, the general feeling is that patients with the UBA1 mutation, they may have low risk MDS. So they have a very low risk of getting AML. We've actually never seen a Vexas patient get AML, and it's never been reported. But their risk of progressing to a severe multi-system uncontrolled inflammation, that's where the mortality is coming from. So it's sort of not fair to use the prior risk scale for it. And I think that the hematologists and hematopathologists are sort of, this is a debate. Normally the risk score is about progression to a severe cancer, but now we're talking about progression towards a severe inflammatory disease. So I think that there's a lot to be done there, but I do think it impacts outcome.
Thank you. You answered two of the questions with that, so that was good. Thank you for the great answer. Our next question is, can UBA1 mutations be identified in peripheral blood?
They can be. Actually, the majority we found in peripheral blood. Bone marrow is probably a better place to test. The place where we can't find it is in the saliva or buccal swabs because it's restricted to the blood. But if you have a sample from peripheral blood, it's easy enough to test. The UBA1 MDS conversation, MDS ends up being an incredibly heterogeneous disease. Probably some people here know people who've progressed quickly to AML and others who've had indolent disease that hasn't progressed. So because we only sequence a subset of genes, a small amount, we know some risk factors, but we don't know more risk factors. So it's very possible that UBA1 and many other drivers may defining other courses in disease, not just AML, but progression to other. So it's sort of opening up a new idea about why people have the symptoms of MDS, low blood counts, right? It could be for many different reasons, including UBA1, including the sort of inflammation.
Thank you so much. This question says, my husband has been diagnosed with MDS and Sweet syndrome. However, doesn't have any symptoms of Vexas. Would you recommend he be tested for the UBA1 mutation?
Definitely. I would definitely. We don't have a number for that exact cohort, but we have a strong suspicion that the majority of patients who have MDS and Sweet syndrome have UBA1 mutations. That's why those two things co-occur. It's only a matter of time before guidelines change, particularly towards having the genetic mutation. That's the goal of the treatment program, the clinical trials, is to make treatments based on the genetic mutation. So getting him a more precise mutation will be helpful. And we've seen many times, I don't know if this happens with him, but that patients with Vexas are taken off steroids and put back on and taken on and off. And it creates this sort of undulating wave of symptoms because we don't like to leave patients on steroids. But actually, in Vexas syndrome, we keep patients on steroids until we have a more definitive therapy because we don't want the inflammation to build up. So in some ways, it may improve quality of life in terms of the cycling on and off of prednisone and sort of a look towards the future of what to do to better improve on treatment.
Thank you. Our next question is, are there different classifications or types of Vexas?
I wish I knew that. It's a really good question. We just published a paper. I tried not to be too molecular. It's hard for me not to go into a lot of detail, but we were looking at a natural history study of all of our Vexas patients that we found to try to figure out a little bit what you're asking. Are there risk factors for becoming severe, not severe, more milder disease? We found some of the mutations are risk factors for severe disease, and also having transfusion dependence is a risk factor for severe disease. We haven't made any subclassification, but I'm sure other people will call it, Vexus MDS, Vexus lupus. In the end, I think the genetic mutation defines the disease, and then the manifestations come afterwards.
Great, thank you. Does Vexus present in one form more than another form? I think you answered that earlier, but does it present in one manifestation over another?
This is one of my favorite questions because I think, we didn't know this disease until a year and a half ago, and we learn as we go. So I'm constantly surprised by the phenotypes that we see driven by UBA1 mutations. What I mean by this is that when we make clinical diagnoses, we report them, and then other physicians find patients with the same manifestations. And it's a self-fulfilling prophecy. It ends up being true over and over again. But that doesn't tell you the expansion of the manifestations of the disease. So, there are many different presentations of Vexus. And I think that one of the salient features is inflammation and having macrocytic anemia. If you had asked me a year ago, I would have said relapsing polychondritis would almost be required. Now I don't think so. I think it's having macrocytic anemia and some inflammation. It doesn't necessarily even need to be severe, just some systemic inflammation. That would make me suspicious enough to test.
Thank you. Our next question is, what about platelet count in Vexus patients in your experience?
It's low in the vast majority of individuals. We see that they're having bone marrow failure, multiple lineages. We don't have good. We see, it's hard because platelet count is multifactorial with treatments, but anemia seems to come before platelets. But platelets are usually decreased, and it's very meaningful that they're decreased. I mean, sometimes they're not very low, although sometimes they are, bleeding risk low. But it's meaningful because platelets can be increased when patients are inflamed. So you have this disease where there's severe inflammation, but the platelets are very depressed. But that's it can be a common manifestation. It's hard to use that as a way to latch on to a diagnosis.
Thank you. If a female has a male donor for a transplant, is that a consideration?
Well, so we simplified things for the presentation, but we've actually identified some women that have the mutation who have Vexas syndrome. And sometimes it's because they've lost an X chromosome. It's a part of normal aging that women can become monosomic in some cells, lose one of their X's. But in some cases, we can't figure out why they have disease despite the fact that they have two X chromosomes. The vast majority of identified patients are male with a mutation, but still females can have it. So I think in the end, donor testing will be important no matter who the donor is.
Thank you. So this is going to be a two-part question. The question is, my husband had a transplant for MDS, and he now suffers from skin GVHD. Could this be skin GVHD, or is it Vexus? And would one suspect that a transplant would take care of the UBA1 mutation?
For the second part, before we talk about GVHD, transplant, if there's bone marrow mutation of UBA1, can be curative, meaning if you've removed, use ablative therapy to eliminate the bone marrow and then given back bone marrow that doesn't have the mutation, it's curative. It comes with all the bone marrow transplant related potential adverse events. in terms of infections, engraftment, graft versus host. But in the general sense, it can be curative, and it's a little bit tricky because sometimes there's age limitations for bone marrow transplant because it can be a very stressful for the body procedure. And this is a disease of elderly male or middle-aged elderly males. So there's a little bit of a tricky part about figuring out when we should be transplanting. To your question about graft versus host disease, I'm not a hematologist, and then on top of that, I'm not a transplant person. So I don't know how they define the graft versus host versus the skin manifestations that we would see in Vexas, how that exactly works. Graft versus host is a very common complication that occurs during transplants. So it's possible that the MDS originally was UBA1 and then it didn't get wiped out and then started to get the skin symptoms from UBA1. But I would think, and probably it would be important to test for it, but I would think that there's some hallmark signs of graft versus host that the team is looking at. And I'm sorry to hear about that.
Thank you. Our next question is, what is the exact mechanism of Lexnobid in Vexas, treatment for Vexas?
Sorry. Yeah, absolutely.
Ruxolitinib.
Yeah, the commercial name, ruxolitinib. That's great.
Yes.
The commercial name for it is Jakafi, which is slightly easier to say.
Yes.
So that inhibits a pathway called the JAK-STAT pathway. That is a pathway that is targeted with lots of different drugs for inflammation or blood cancers. And we see that pathway is upregulated in Vexas syndrome. It's upregulated in a lot of different diseases, but it's upregulated in Vexas syndrome. So it's not as specific to Vexas, but it seems to be an effective therapy. We are seeing that patients eventually, the response can diminish with time. So we're even more anxious and eager to find a better treatment. And from our standpoint, we're so excited that we can identify patients because then we can better study agents and drugs as opposed to only having a few individuals. And it's hard to make these anecdotal assessments based on a couple retrospective studies. Be able to go forward and build a clinical trial to prove efficacy. Then we can come back and hopefully and give you guidelines, right? And generate guidelines with our international community.
Thank you. Our next question is, for Vexas patients, do we know what the safety of receiving the COVID-19 vaccines are?
Another really good question. This is like better than my scientific talk questions. So that's a testament to probably the dedicated members of the community. So we don't really know. We do have a ton of evidence that patients respond to the vaccine, so they're able to make antibodies. And we recommend that everyone who has Vexas gets the vaccine. We haven't seen anything like they have severe inflammatory response to getting the vaccine. What I will say we have seen a lot of patients get COVID and get very, very sick from it with Vexas. So you're talking about a disease where you have severe inflammation, and then that's Vexas, and then you're talking about an infection that causes severe inflammation. And the two things might be a powder keg. Again, this has not been studied in any organized manner, but that's why we're eager. And I think across all diseases, there's been a real push to make sure that people are vaccinated because it's an effective way to prevent infection, and infections can be fatal, right? So that's my picture of it. And we haven't seen anything on the vaccine side. But good question.
And what do you foresee the future of Vexas syndrome?
I foresee the future being like the present for Vexas, meaning that we build out understanding of the clinical manifestations cohort by cohort and build out better treatment with treatment trials. Where I think that my biggest excitement about Vexas is that there are adults out there, they come to our clinic every week who don't have diagnoses, who live in the in-between space of hematologic and rheumatologic diseases. They may or may not get the MDS diagnosis, but even if they do, no one feels like it's clearly defining their symptoms, that those individuals may have genetic causes that then will lead to another cycle of being able to provide these patients diagnosis and then the light towards treatment. I think Vexas, we're going to have better treatments. We're going to have a better understanding. We already do every day. Just today, there was a big international consortium that published guidelines and goals for how to manage and think about Vexas. So that's going to continue with or without, that will continue to progress just like the nature of knowledge. But the next undefined MDS, because we only make a diagnosis somewhere around 50% of individuals that come to our clinic with Vexas-like symptoms. What's happening in the rest of the individuals? What's happening in the individuals that aren't Vexas-like but have some atypical MDS manifestations? Are they driver mutations that are not on the 40 gene panels? And can we help identify and help those individuals?
And do you foresee in the future that, I think you mentioned this, that Vexas will be included in the clinical workup for MDS patients?
Well, nothing's for certain. I think it's very likely. Some countries have already moved to that. In the UK, they have it on every panel in some of the hospitals. Some single hospitals are using that, and some companies are. But there was just a big consensus statement from one of the hematology communities that put Vexas into the category. Some of the companies are taking on to that, and we'll start testing. It just takes a little bit of time. Now, unfortunately, I'm not very patient, so I was trying very hard to get companies to add it. So the gene, and it hasn't been very, it hasn't worked just by me saying to add it, but I can see it slowly picking up. 6 months ago it was on 0 panels. Now it's on 2, and with the amount of research that's going on, I can't imagine it won't be on considerably more in the near future. Like my boss, like my mentors have told me to be patient. So with a little patience, it will be on all panels, I think.
Right. Well, thank you so much, Anna and Dr. Beck, for the wonderful presentation and taking all the time to answer all of these great questions from everyone that is with us today, and those who sent in questions ahead of time to be answered. So thank you again for sharing your time and your expertise with everyone today. And if you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, please feel free to send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 38 years. This concludes our program. Thank you again.
Thank you.